Cancer. Today we have Dr. Santosh Kumar Chala from. Sir is a consultant medical oncologist from Star Hospitals, Hyderabad. Sir, over to you.
Thank you, Sandeep. Thank you, Bayer, for providing the opportunity. So I'll just share slides. So today we would be discussing on the role of Nubeqa, that is darolutamide, and how is the prostate cancer landscape in 2026? How are we treating? To discuss this, we have two eminent speakers in this program. It's my pleasure to invite Dr. Shravan Kumar Dubasi. He's a consultant medical oncologist at KIMS Hospital, Minister Road, Hyderabad. We have another Dr. Shravan Kumar Chintala. He's a consultant medical oncologist, Renovo Soumya Hospital, Hyderabad. So welcome you both. So it's my privilege to invite them. And also, these are my dear friends and colleagues. We know for the past maybe 10 years, each of them. So I hope the discussions would be very interactive. To tell about Dr. Shravan, he has got his qualifications from of the premier institutes like All India Institute, including Dr. Shravan Chintala from the Tata Memorial. So we have two speakers with eminent academic background. So we hope the session would be scientific enough. So the overview of the meeting would be, we would have an initial 20 minutes discussion in reaching heights in MS HSPC by Dr. Shravan Kumar Dubasi, followed by darolutamide can be used without chemotherapy, that is erroneous evidence by Shravan Kumar Chintala. Then we have some practical discussions and few theoretical or the questions which we have day to day that we will discuss, and we will end with question and discussion. So what I thought was, during the preparation of this presentation, this was the brochure or flyer provided by Bayer. So I thought this is a little bit monotonous, boring. So I thought, why shouldn't we use the use of AI in the presentation, where we are using of late a lot of AI. So I've asked AI to prepare a presentation of me moderating the session with Dr. Shravan Dubasi, Dr. Shravan Chintal as moderator. This is what is given by AI. So, Shravan, are you okay with your photo? Shravan Dubasi?
Sir, yeah, it's okay, sir. I look more senior.
Dr. Shravan Chintala, you look similar, or
this is much better version of mine, sir. I'm looking more smarter.
to accomplish this, it's not very easy. So it gave something like this in the initial. So AI always makes mistakes. AI can never replace our human touch. So with this, what I would do is, we are seeing a lot of landscape changes in the management of prostate cancer. It was started with where there was only hormonal therapy, do orchidectomy and do nothing. That is where the prostate cancer treatment has started. Then in 2010 to 2015, we have multitude of clinical trials when they have added additional agent to androgen deprivation therapy, that is adding chemotherapy or another newer hormonal agent. The chemotherapy is docetaxel. So we understood that doublet is superior over single ADT. That second agent could be chemotherapy, or the second agent could be any newer hormonal. That is how clinical trials have evolved. Now we are seeing clinical trials where should we give three agents. So we have two such protocols. So where we use a combination of the ADT, newer hormonal, along with chemotherapy. We have two protocols with that. And there is much more emerging evidence that why can't we eliminate chemotherapy? In the process of eliminating chemotherapy, using a stronger newer hormonal agent in the form of darolutamide, will it give us good suppression of PSA, prolonged survival? And this is how the research question is going on. Possibly, genomically, if we understand more in the future, especially those cases which are BRCA positive, possibly we can get away with chemotherapy. This is how the field is moving. But one important consideration, especially we deal with prostate cancer, is the people are very fragile, elderly, lot of comorbidities. There is a lot of pill burden. There is a lot of drug-to-drug interaction. These are all the problems that we face whenever we see an elderly patient with prostate. So these are the things we see in day to day. So with this background and setting the background, so what I would request Dr. Shravan Dubasi and Dr. Shravan Shrintala is, so to present what is the scientific evidence, their experience with dalalutamide. So later we would have real discussion what are the practical implications in following the scientific evidence. So translation to the real world, how it is facing, are we able to do, what are the difficulties we face, we will deal in the question and answer in the follow-up session. So I would invite esteemed speaker, Dr. Shravan Kumar Dibasi, to give us an update over use of darolutamide in HSPs. Over to you, Dr. Shravan.
Thank you, sir. Thank you for setting up the context. I will share my slides and then we'll start. Okay, 1 second. So today I will be discussing mainly about the Arasens trial and how the landscape of prostate cancer has changed over years with the highlight on Arasens trial. So these slides are provided by me, by Bayer to me, and this is their disclosure. I have nothing to disclose. So this is the prostate cancer landscape. Usually majority of the times, like 90% of the times or more than that, prostate cancer is diagnosed locally or in the locally advanced stage. So once it is diagnosed, it is treated with either radical prostatectomy or radiotherapy. And depending upon the risk stratification and risk, basically adjuvant ADT is given or may not be given. So if it's not given or given, and patients are regularly followed up with PSA, usually we follow up only with PSA in the local disease. We see biochemical recurrence, and depending upon the pace of rise of PSA, we either treat or just observe. So once there is a biochemical recurrence, and if ADT is used, then it can develop into non-metastatic castrate-resistant prostate cancer. And ultimately, even after this treatment, it evolves to metastatic castrate-resistant prostate cancer. And after multiple lines of treatment, ultimately, patient may succumb to prostate cancer. So if there is biochemical recurrence, again, it may, if ADT is not used, it evolves to castrate-sensitive prostate cancer, which is metastatic, or it might not be metastatic also. In that case, ADT is given, and later, after a few years of this ADT therapy, it evolves to metastatic castrate-resistant prostate cancer, and ultimately patient again will succumb to prostate cancer. So patients who suffer and die of prostate cancer all have metastatic prostate cancer. And in this castrate-resistant prostate cancer, OS improvement is approximately 2.5 to 4.5 months. So there is a lot of scope here for because biology of prostate cancer is relatively aggressive, relatively less aggressive. So if treatments are added which inhibit this cancer progression, so life can be extended significantly, and there is scope of further improvement. So this is the study which Stampede trial result, primary arm where ADT along with or without docetaxel was given. This study, Stampede trial, which was published in 2015, showed that ADT alone or without docetaxel, which was actually later added in Stampede trial, it showed a median PFS of 11.2 months and a survival of approximately 42 months in these patients who have castrate-sensitive prostate cancer. So definitely there is much to do, and medications can be used to further improve the survival. This is another arm of Stampede trial where ADT plus plus or minus docetaxel is compared to that of consolidative radiotherapy, which is given to prostate at the end of the therapy. If it is low volume, like less than 4 bone mets, it has significantly improved failure-free survival with hazard ratio of 0.56, and it's clinically significant. And it has improved in overall survival too, compared to that of standard of care. Whereas if patients have greater than or equal to 4 bone metastasis, which is high risk, there is no significant improvement of adding consolidative radiotherapy to prostate. It did not improve any failure-free survival or overall survival. So this is the money slide, which is showing all the trials of prostate cancer and the evolution of prostate cancer treatment in castrate-sensitive prostate cancer. So the first trial and the main, it is the treatment paradigm has shifted in 2010s, and now we have like it in 2010s it was doublet therapy. Now we have triplet therapy with significant improvement in overall survival. The first study which evaluated along with ADT, which was the standard of care at that time, to which docetaxel was added, and it included both low risk and high risk prostate cancer patients, which means high volume and low volume prostate cancer patients. And it did not, so though there was clinically meaningful improvement, but there was no clinically significant benefit in overall survival with hazard ratio of 0.88, and the confidence interval was crossing 1. Whereas charted study, again, to the standard of care of ADT, docetaxel was added with hazard ratio of 0.72, and which was clinically significant. Next comes Stampede trials, which has arms of from A to nearly J, like multiple arms are there. In this, the standard of care was ADT, and docetaxel was added in the middle, like in 2015s, when it showed that docetaxel has significant benefit. So later they started adding docetaxel after amendment. So to this standard of initially only ADT was the standard of care. So ADT and ADT was compared with the docetaxel, and it had showed clinically meaningful and clinically significant benefit with hazard ratio of 0.8. Again, the Stampede trial, where ADT was compared to abiraterone, acetyl, and prednisolone, which also showed significant benefit with hazard ratio of 0.6. Coming to the Latitude trial, where again same abiraterone was compared with that of placebo, only ADT was given, and which also showed significant clinical benefit with hazard ratio of 0.66. Coming to enzalutamide drug, which is Arches trial, it was also compared with placebo, and hazard ratio was 0.66, which is clinically again significant. Coming to the Titan, where apalutamide was evaluated along with compared to that of ADT alone, and it had hazard ratio of 0.65, which is clinically significant. And next is Enzamet study, where enzalutamide was compared to that of enzalutamide along with ADT was compared to that of ADT plus non-steroidal anti-androgens like bicalutamide, flutamide, and nilutamide. It also showed significant clinical benefit with hazard ratio of 0.67. And then after all these doublet studies, in 2021, there was a triplet study, which is the PACE trial. Again, it is multi-arm study, where ADT along with docetaxel was compared to that of ADT, docetaxel, and abiraterone. And it did show clinically meaningful and significant benefit with hazard ratio of 0.75, and confidence interval was less than 1. Now, this formed a basis for the doralitamide study, which showed that adding docetaxel to the ADT has definitely clinically significant benefit, and even triplet was showing clinical benefit. So this made basically setting for Arasen study, where doralitamide was added to ADT plus docetaxel. So we will see in detail about the Arasen study. So this is actually this is what we have discussed. I have discussed already. So in charted trial, where ADT was compared along with ADT and docetaxel, it showed clinically meaningful benefit and significant benefit in high volume disease compared to that of low volume disease. Here we can see the median survival is 51 months compared to that of 34 months in docetaxel arm with hazard ratio of 0.63 and clinically p-value of less than 0.001. Whereas in low volume disease, the median overall survival in docetaxel plus ADT is 63.5 months, whereas it was not reached in ADT alone arm, and there was no improvement in overall survival. So this is the latitude trial where abiraterone was compared with placebo along with ADT and abiraterone along with ADT. The median survival in ADT plus abiraterone was 53.3 months, whereas it was 36.5 months. The benefit was clinically significant. However, the patient had significant side effects because of this abiraterone and prednisolone. Let's see about that. So it showed. So other secondary point, other than overall survival, other secondary points included pain progression. It also was clinically significant, and the median pain-free progression was 47.4 months versus 16.6 months. The skeletal related events was not reached in both the arms. Chemotherapy initiation was not reached in abiraterone group, and it was 57.6 months in placebo plus ADT group. And the subsequent prostate cancer therapy was received in prostate cancer therapy was the median duration for subsequent prostate cancer therapy was 54.9 months in abiraterone plus prednisolone group, whereas it was 21 months in placebo plus ADT group. And prostate specific antigen progression was 33.3 months in abiraterone group, whereas it was only 7.4 months in placebo plus ABT. So abiraterone was the first to show the hormonal treatment can be effective. However, it is important to understand the treatment journey of the control arm when interpreting this data. Because even with the 5 milligrams of prednisolone in abiraterone plus ADT group, where prednisolone was 5 mg, it has significant side effects like hypertension, hepatotoxicity, hypokalemia, cardiac disorders, fluid restriction, osteoporosis, and cataract. This was seen compared to that of ADT if it is used upfront, and when it was crossover, and when the same regimen was crossed over, the incidence of these side effects were numerically less. Of course, the numbers are different. Coming to the Titan trial, where apalutamide was evaluated, again it showed significant progression-free survival with hazard ratio of 0.48 and overall survival hazard ratio of 0.65 with p-value of less than 0.001. This is the only drug where it showed benefit in both the low volume disease and high volume disease compared to that of abiraterone and enzalutamide, where the significant difference was in high volume disease. Coming to the enzalutamide, again it was compared with the ADT plus non-steroidal anti-androgens. It had a good clinical progression-free survival of hazard ratio of 0.41, which was with p-value of less than 0.001, and overall survival of 0.67 hazard ratio with the p-value of 0.002. Here we can see that again it did not show significant benefit in high volume disease, where hazard ratio of 0.8 and hazards are crossing 1, whereas in low volume it showed significant benefit. To the combined therapies, which coming to the combined therapies, which Peace 1 study and ARASENT study. In the Peace 1 study, as I said, it is a multi-arm study which included patients of de novo metastatic disease. Recurrent metastatic disease was excluded, and patients who received prior chemotherapy were also excluded, and they were stratified based on high volume and low volume disease. And other inclusion criteria included 3 months of less than or equal to 3 months of ADT prior to randomization, no prior cytotoxic chemotherapy or biological therapy, and they were stratified based on ECOG PS, metastatic sites, lymph nodes, bone versus visceral, type of castration, whether orchidectomy was done or LHRH agonist or antagonist was given. So they were randomized into 4 arms in 1:1:1:1 randomization. And arm A standard of care was ADT alone and ADT plus docetaxel. Arm C standard of care plus radiotherapy. Whereas arm B standard of care with abiraterone. Arm D standard of care abiraterone and prednisolone. Here in Arasen's trial, basically the comparison is between arm A and arm B. Arm B. So coming to the overall survival in this Arasen's peace trial, comparing that of comparing ADT docetaxel abiraterone versus only ADT docetaxel in high volume disease, it clearly shows the median survival is approximately 5.1 years in triplet arm compared to that of 3.5 years in standard of care with hazard ratio of 0.72, which was with significant p-value. Whereas in low volume disease, in both standard of care and abiraterone, standard of care plus abiraterone, it did not show significant benefit. In both the arms, it did not reach median overall survival. This led to the confirmation that in high volume disease, you could improve outcomes by adding abiraterone to the docetaxel compared to that of docetaxel alone. In low volume disease, it didn't seem to be beneficial as out of high volume disease. Coming to Arasen's trial, this is a global randomized double-blind placebo-controlled phase 3 trial where patients included were metastatic hormone-sensitive prostate cancer with ECOG PS less than or equal to 1 and candidates for ADT and docetaxel, and stratification was done based on metastatic disease and alkaline phosphatase levels. So to the standard of care, which is ADT plus docetaxel, doralitamide was added at 600 mg per BD, and the primary endpoint was overall survival, and it included multiple secondary endpoints. Important are time to castrate-resistant prostate cancer, time to pain progression, symptomatic skeletal event-free survival, time to first symptomatic skeletal event. So 80%, 87% patients received all 6 cycles of docetaxel. Adverse events between arms were almost identical. Coming to the results, the median overall survival among the standard of care in standard of care was approximately 49 months compared to that of doralitamide arm, which did not reach median overall survival. And at the end of 50 months, that is the median survival in standard of care, approximately 50%, nearly 63% patients were progression-free, had progression-free, overall survival in ADT plus standard of care plus doralitamide arm with hazard ratio of 0.68 and significant p-value. So benefit is seen in all subgroups irrespective of low volume and high volume disease. Here in high risk disease, we can see that the median again has not reached in the doralitamide arm compared to that of 43.2 months in the standard of care with hazard ratio of 0.71, which is significant, and hazards are not crossing 1 again. In low risk patients also, it showed in both the arms, though the median has not reached, but the doralitamide group has showed significant benefit with hazard ratio of 0.6, which means it has, compared to that of standard of care, there is 40% risk reduction in decreasing the death in these patients. So it is useful in both low volume and high volume disease compared to that of this peace trial where it is beneficial only in high volume disease. So these are the key secondary endpoints, which is the time to castrate-resistant prostate cancer. In doralitamide arm, again, it has not reached the median. Compared to that of standard of care, it is 19.9 months. There is 64% reduction in risk reduction with hazard ratio of 0.36 and significant p-value. And time to first subsequent antineoplastic therapy, again, doralitamide did not reach the median, whereas in standard of care, it was 25.3 months with 61% of risk reduction. The other secondary endpoints include time to pain progression. In doralitamide arm, it has not reached to the median, whereas 27.5 months in the standard of care with 21% risk reduction. Time to first symptomatic skeletal event in doralitamide arm and in standard of care arm, it did not reach the median. However, there was significant 29% risk reduction. So seeing the PSA responses and the outcome, here in doralitamide arm at 24 weeks, we can see that in nearly 48% of the patients, the PSA was undetectable, whereas in ADT plus docetaxel alone, it was 23%. If you see at 24 weeks, at 36 weeks, at 52 weeks, and or any time, it was in the range of 23 to 30 only in standard of care arm. However, when dorolutamide is added at 24 weeks, it was 48.7 months. It was 57 months at 36 weeks, 57% at 36 weeks, 60% at 52 weeks, and 67% at any time if we take with dorolutamide. So here we can understand with the dorolutamide, and if we are giving dorolutamide continuously, the responses are deepening compared to that of standard of care alone. So if the TSA is undetectable at 36 months, how is it going to be? How the response is going to be later? So if PSA is undetectable at 36 weeks, and if patient is continuously taking dorolutamide, the median has not reached in these patients. However, if PSA is detectable and at 36 weeks, the median has dropped. So it indicates this is failure-free survival with significant with hazard ratios of 0.3, 0.23. Even this is failure-free survival. Even in the overall survival, when PSA is undetectable at 36 weeks with triplet arm, so it shows significant benefit compared to that of if PSA hasn't shown. PSA is not undetectable at 36 weeks. Here we can see if it is undetected, it has median has not reached till now, and if it is detected at 36 weeks, median is 33.3 months with hazard ratios of 0.3. Again, that is overall, what we have seen is in overall population. Coming to the high volume metastatic HSPC population also, again, here we can see that if dorolutamide is added, it is progressively helping in deepening the response, and we can see number of patients who are getting PSA undetectable is increasing. At 12 weeks, it is 25% and 14%. At 52 weeks, at 1 year, it is 54% versus 23%. Again, seeing the failure-free survival, if PSA is undetectable at 36 months, we can see even in high volume disease that median failure-free survival has not reached. Whereas if PSA is detectable at 36 months, median is 36 weeks, median is 28.9 months with hazard ratio of 0.2. Coming to the overall survival, again, median is not reached if PSA is undetectable at 36 weeks in dorolutamide arm, whereas it is 22.1 months with hazard ratio of 0.3 in standard of care. So dorolutamide triplet has achieved long periods of no disease progression and also significant improvements to overall survival with increased or deepening responses. So in low volume disease, also here we can see the PSA has significantly reduced over time. It has reached near to 85% at any time and 38% in standard of care. Again, if PSA is not detected, it has shown dorolutamide has shown much better benefit compared to that of ADT and placebo with hazard ratio of 0.09 in failure-free survival. And same goes with overall survival also. If PSA is undetected at 36 weeks, the median has not reached in dorolutamide arm, and even in low volume disease here, even in if PSA is detectable, the median has not reached. However, the benefit is very high. We can see hazard ratios of 0.34, which is not crossing, confidence intervals are not crossing 1. So things to consider before giving therapy. We all know that any patient who is young and fit, if we give like triplet dose of or any high intensity of therapy, it benefits the patient because it increases the progression-free survival, and ultimately overall it can increase overall survival also. Many times if we start with like singlet or doublet, later we might not get a chance to give triplet to those patients. So we need to consider many factors before giving therapy, like patient is able to tolerate and accept docetaxel or not, extent of disease, whether it is high volume disease or low volume disease, likelihood of hormone insensitive clones, age and life expectancy, definitely we should consider this. If patients are like 50 and 60s, definitely we should go for triplet therapy, which gives them progression-free survival, which is very important in these patients. So hit hard and early, because prostate cancer will be the cause of death ultimately. Will docetaxel be an obligation in the near future? We have to test. Future trials will evaluate that. Much less effective. So if we don't treat them later, like if abiraterone is given, we cannot give enzalutamide. It does not show benefit significantly, and same goes with if enzalutamide is given prior. Uh, Abiraterone cannot does not have significant benefits. So it is better to use. It's better to use triplet initially. So patient should be informed about all the available options, and after discussion with the patients, uh, after informed decision can be taken by the patients. Thank you.
Thank you, Dr. Shravan. You have very well discussed the evolving role and better control in case of prostate cancer using available better agents, using a triplet combination, with the use of which we can give our patients good overall survival, good quality of life. And of course, the initial docetaxel part might be something problematic. After that, it's eventually, as you have discussed, like with minimum side effects and no interactions. With this, I would invite my second speaker, Dr. Shravan Kumar Chintala. The stage is yours, Dr. Shravan. Can we see the
Can I share?
possibility of chemotherapy regimen? Yeah,
Yeah.
you can share.
Sandesh can share.
So he would be discussing
Yeah,
whether
yeah. Oh,
it's possible to get chemotherapy. Yes.
yeah. Give me a minute, sir. My colleague is sharing the slides. Thank you. Padma, are you there?
Yes, I'm sharing.
Yeah, please. Thank you. Sir, I hope you can see the slides, sir. Yeah, please go ahead, sir.
Yeah, I can see the slides. I hope I'm audible and the screen is visible to everybody.
Yes, sir.
So, my topic for today's discussion, so the advancing metastatic HSPC treatment horizons, mainly the role of darolutamide, Nubeqa, without addition of chemotherapy. So the evidence is from the ARANOTE study. Next slide. So the slides are provided by Bayer Pharma. So this is their disclosure, nothing from my side. Next slide. So this is a treatment landscape, how the treatment has evolved from docetaxel to the newer ARPs, from doublets to triplets in metastatic HSPC setting. I think Dr. Shravan Dubasi has detailedly elaborated this slide. So I think I may go to the next slide so that I can discuss the ARANOTE study without wasting time. So, this is an unmet therapeutic need, especially in a patient of metastatic hormone sensitive prostate cancer, because they are elderly people and they will be frail and having lot of comorbidities, and there is a polypharmacy associated with a high pill burden. So, the main important concern for these patients is safety profile when we use this newer ARPS, and also the patients are having polypharmacy with a high pill burden. The existing treatment may have drug potential interactions. So this is one of the therapeutic unmet need, even though we have a plethora of agents of ARPI and with various efficacy profiles across the drugs and studies. So ARASENS is a phase 3 study in combination with the docetaxel, which has already showed beneficial efficacy and safety profile, as we have discussed in the earlier session, in a metastatic HSPC, and it has led to approval in our country in 2023. But in a combination of ADT along with darolutamide without chemotherapy backbone, has also had a safety profile and efficacy from the data of RNO trial data. And the good important thing about this study is this is a one study where we have good number of Indian patients. So with this RNO data, darolutamide has the potential to change the treatment paradigm, and it would be the only androgen receptor pathway inhibitor which could be used with and without chemotherapy. So in ARASENS study, it has a triplet combination regimen, and in ARANOTE, it is a doublet combination regimen along with ADT. So it has both the advantages as per the data and trial data available as of now. Next slide, please. So this is a background of the study. Darolutamide plus ADT with docetaxel is the standard of care in metastatic HSPC. In ARASENS, darolutamide along with docetaxel and ADT, which has demonstrated safety, favorable efficacy and safety when compared to the doublet regimen, that is ADT plus docetaxel in patients of metastatic hormone-sensitive prostate cancer. Whereas in ARANOTE, it has mainly evaluated the role of darolutamide along with ADT when compared to ADT plus placebo as a newer treatment option for metastatic HSPC patients, where we can potentially spare docetaxel. Next slide. So this is a trial schema. So ARANOTE is a double-blind phase 3 controlled study. So it has two components. One is double-blind phase until the primary analysis being done, and the second component is open-label phase once the primary analysis is done till the final analysis. So the patient population number of patients were 665, and mainly metastatic hormone-sensitive prostate cancer who are histologically or cytologically confirmed to be adenocarcinoma of the prostate, with a ECOG performance status of up to 2 were allowed, and main stratification risk factors being visceral metastasis and also the prior local therapy, whether they have received yes or no. And it is a 2:1 randomization into darolutamide of a dose of 600 milligram BD along with the ADT, and to 1:1 randomization, one is to 1:1 ratio of placebo plus ADT. So we have a number of endpoints here, but the primary endpoint being radiographic progression-free survival, and key secondary endpoints being overall survival, and time to initiation of subsequent anti-neoplastic therapy, and time to castration-resistant prostate cancer, time to PSA progression, and the rate of undetectable PSA, which is defined as less than 0.2 nanogram per ml, and time to pain progression as per the criteria of a brief pain inventory short form, and the safety profile. And the other pre-specified secondary endpoints were also there. And in the open label phase, that is after the primary analysis until the final analysis, it has been switched to open label of darolutamide, where the placebo arm can be 100% crossover to the darolutamide arm. So the data cutoff being June 7, 2024, with a median follow-up in the darolutamide group being 25.3 months compared to placebo of 25 months. Next slide. So these are the patient demographic and clinical characteristics at baseline, the median age being 70 years in both the arms. And one good important thing about these studies, it has a very good Asian representation of around 1/3 of patients, that is around 33% in both the arms, patients being Asians. And de novo metastatic patients are predominantly, that was around 70% compared to the no recurrent disease in 22%. And high volume disease accounts for around 70.6% compared to the low volume around 29%, and which are both the both these characteristics are both matched in both the arms. And whereas visceral metastasis is present in around 12% in the darolutamide arm compared to 12% in the placebo arm, and no visceral metastasis being around 88% in the darolutamide arm compared to 88%, which is similar in the placebo arm also. So with respect to the baseline demographic characteristics, both groups were well matched with a good representation of Asian ethnicity. Next slide. So this is the country representation across the breakthrough clinical trials for prostate cancer. So next slide. So this is a RNOT study where the Asian subgroup of patients were included. So with contribution of around 13% in from India in both the groups, and Chinese and Taiwan people were also included. The only thing there is underrepresented population group in this study will be from the African continent, but otherwise Asian population are reasonably represented. Next slide. So coming to the efficacy analysis, the primary endpoint, as I highlighted, it is a radiographic progression-free survival. So darolutamide along with ADT significantly reduced the risk of radiological progression or death by 46% compared to the placebo plus ADT. So here hazard ratio being 0.54 with a significant p-value, and when compared to the placebo plus ADT, darolutamide plus ADT arm, the median was not reached, and the median follow-up in darolutamide arm being 25.3 months compared to placebo of 25 months. Next slide. So if you see the subgroup analysis where the darolutamide plus ADT in terms of radiographic progression-free survival compared to placebo plus ADT. So in all the subgroups, whether it is high volume disease versus low volume disease, or across the age subgroups, or baseline PSA value, or performance status, or Gleason score, and whether it is with respect to the different racial representation or geographical region or visceral metastasis, whether they have received prior local therapy, yes or no, irrespective of the subgroup analysis, this darolutamide plus ADT harm has favored in all these subgroups when compared to the placebo plus ADT. Even in both the high volume and low volume groups have been benefited with this doublet regimen when compared to the placebo plus ADT arm. Next slide. So in one important point is, so in this subgroup analysis with respect to the volume of disease, whether it is low volume or high volume, both the groups have benefited. The low volume group has a bit of more delta value with a hazard ratio of 0.3 compared to 0.6 in high volume group. So both the groups have been benefited, though the magnitude of benefit bit more in low volume compared to the high volume subgroup. Next slide. So coming to the secondary endpoints, so as we know that the key secondary endpoint being overall survival. So with respect to overall survival, the darolutamide plus ADT arm has benefited when compared to placebo plus ADT arm with a hazard ratio of 0.81. And with respect to time to metastatic castration-resistant prostate cancer, or time to PSA progression and time to initiation of subsequent systemic therapy for prostate cancer, even time to pain progression, that is health related quality score also, which has favored the darolutamide arm compared to placebo arm with the significant hazard ratio in darolutamide arm. And the other important point about this study, when the primary analysis was done, OS data was immature, and the all remaining per protocol placebo patients offered crossover to darolutamide after the primary analysis, as I highlighted in the trial schema. Once the primary analysis has been done, till the final analysis, the placebo 100% has crossover to the darolutamide, the study arm. Next slide. So with respect to the secondary endpoints, the darolutamide arm plus along with ADT, when with respect to the time to metastatic CRPC, so it has significantly better when compared to the placebo arm with a hazard ratio of 0.4, and the median was around 13.8 months in the placebo arm compared to the median which is not reached in the darolutamide arm. So there is a significant benefit with respect to time to metastatic CRPC. and the other secondary endpoint being time to pain progression. So the hazard ratio of 0.72 in the darolutamide plus ADT arm compared to placebo plus ADT arm with a significant p-value. And the median was not reached in the darolutamide arm compared to 29.9 months in the placebo arm. So delay in pain progression can be of high importance to patients, and it has been demonstrated with darolutamide plus ADT arm with a significant benefit with respect to time to pain progression. Next slide. And if you see the other secondary endpoint, the PSA undetectable, that is less than 0.2 nanogram per ml at any point during treatment. So in the darolutamide arm, it is around 62.6% compared to the placebo arm, which is around 18.5%. So there is a significant proportion of patients in the darolutamide arm who have been achieved this PSA of less than 0.2 nanogram per ml compared to the placebo arm. And time to PSA progression also in the darolutamide plus ADT arm, the hazard ratio being 0.31 compared to the placebo plus ADT arm. And the median was not reached in the darolutamide arm compared to 16.8 months in the placebo plus ADT arm. So with respect to the PSA point nanogram per ml and also the time to PSA progression definitely favor darolutamide plus ADT arm compared to the placebo plus ADT arm. Around 63% of patients in the doublet arm attained PSA less than 0.2 nanogram per ml, which has represented around 69% improvement in the time to PSA progression in the darolutamide arm compared to the ADT plus placebo arm. So as with the RSN's data, even in RNO data also, a higher proportion of patients who have been achieved undetectable PSA, that is less than 0.2 nanogram per ml with the darolutamide arm compared to the placebo arm in high volume as well as a low volume subgroup. If you see at 24 weeks of evaluation, the placebo arm has a 10.8% compared to 44% in the darolutamide arm. Even at 36 as well as 58 weeks also, darolutamide has a high proportion of PSA decline compared to the placebo. And even at any point of time, around 54.6% of patients in the darolutamide arm have a undetectable PSA compared to only 15% in the placebo arm. And the same trend has been observed even in the low volume subgroup also. So at 24 weeks of evaluation, darolutamide arm has around 71.9% of patients who have undetectable PSA compared to around 17.5% in the 24 weeks. Even at 36 weeks as well as 48 weeks, the darolutamide arm has a significant proportion of PSA decline compared to the placebo arm. And at any point of time in low volume subgroup, 82.6% of the patients in darolutamide arm has a undetectable PSA compared to placebo, which is only 25.4%. So with irrespective of the volume of the disease, at any point of time, darolutamide plus ADT has significantly lowered the PSA, that is less than 0.2 nanogram per ml when compared to the placebo plus ADT arm. So the other endpoint after time to pain progression, time to CRPC, and the undetectable PSA level, the other secondary endpoint being time to initiation of subsequent life prolonging anti-cancer therapy. So in darolutamide plus ADT arm compared to placebo plus ADT arm, patients who require subsequent life prolonging systemic anti-neoplastic therapy was around 32% in Dara arm compared to the 42% in the placebo arm. So there is a lesser proportion of patients who do require subsequent initiation of next line of therapy compared to the placebo plus ADT arm. So the most commonly used regimen after the progression on darolutamide being the chemotherapy, which is around 22% in the darolutamide arm compared to 28% in the placebo plus ADT arm. followed by abiraterone and enzalutamide, and apalutamide in 1.5% compared to none in the placebo arm, and cabazitaxel in 1% of the patient compared to 0.6 in the placebo plus ADT arm, and less than 1% of the patients have received PARP inhibitors, that is olaparib, in darolutamide arm compared to none in the placebo arm. So the most commonly used agent post dara progression being in this study being docetaxel. Next slide, please. So after knowing the primary endpoint, that is radiographic progression-free survival, and key secondary endpoints, now this is a data of the safety profile. So the treatment emergent adverse events incidences were similar between the both the treatment groups, that is darolutamide plus ADT compared to the placebo plus ADT arm, and discontinuation rates were lower in the darolutamide arm. So if you see all group of adverse events were similar, that is around 90% in both the arms. And with respect to grade 3, grade 4 events, around 30.8 in the darolutamide plus ADT compared to the same in the placebo plus ADT. So more or less similar adverse event profile, whether it is all grades versus grade 3, grade 4, and including serious adverse events also. But around 9% of the patients who have led to the permanent discontinuation of treatment in the placebo arm, whereas only 6% in the darolutamide plus ADT arm, which were led to permanent discontinuation of the darolutamide drug. And the median treatment duration was around 24 months in the darolutamide arm, compared to 17.3 months in the placebo arm when this safety analysis being done. The safety profile of darolutamide in ARA note was independent of PSA response, and it has a consistent with the favorable tolerability uh, as per the previous data of Aramis and Aracins. Next slide. So even the rate of most common adverse events when we compared between darolutamide plus ADT arm along with placebo plus ADT arm, either they were less or similar between the two groups. The main one of the main side effect of fatigue when we encounter along with the combination of ADT is being fatigue. So in this trial, around 5% in darolutamide plus ADT arm compared to 8% in the placebo plus ADT arm. So fatigue is less common in the study group compared to the placebo arm, even with respect to the arthralgia, anemia, urinary tract infections, or backache, the skin issues like hot flushes, constipation, transaminitis, bone pains, weight gain, hypertension. So there are more or less similar between the groups. And when compared to the enzalutamide arm and the apalutamide arm in Prosper and Spartan data, though we don't want to compare the cross-trial comparison, but we do end up in doing so. When compared to these enzalutamide and apalutamide as per the Prosper and Spartan data, the fatigue risk and the fall or fracture, they're all less compared to the enzalutamide and apalutamide when compared to darolutamide. Even the seizure profile, as we know that enzalutamide is one of the drugs which has a neurocognitive impairment resulting seizures, which is more in enza compared to darolutamide arm. Next slide. So the common adverse events with respect to the androgen receptor pathway inhibitors, even in darolutamide plus ADT arm, when compared to placebo plus ADT arm, they are more or less similar. The common adverse events being hypertension, vasodilatation, diabetes mellitus, hyperglycemia, cardiovascular dysfunction, or neurocognitive abnormalities, or seizures. So these are more or less comparable in both the arms. Next slide, please. So this is a ASCO 2025 highlighting darolutamide has a significant positive impact on health-related quality of life. So as per the data available, darolutamide plus ADT arm has a good health related quality, and the median time to deterioration in functional assessment of cancer therapy in prostate, the total score improvement around 5.1 months in the darolutamide ADT arm compared to the placebo plus ADT arm, around 16.6 months in the study arm, that is darolutamide arm, compared to 11.5 months in the placebo arm. So with a delta of 5.1 months improvement with respect to median time to deterioration in the health related quality of life. And the darolutamide is the first and only androgen receptor pathway inhibitor to demonstrate clinically meaningful improvement in pain progression as well as the overall well-being also. So as a key secondary endpoint being time to pain progression, with this with the availability of a brief pain inventory short form scale, there is a numerical improvement in the time to pain progression with in the darolutamide arm compared to the placebo plus ADT arm. Next slide, please. And the health related quality of life indices as per the FACT-P subscale scores. So you can see whether it is social well-being or familial well-being or functional well-being, and the symptoms pertinent to the urinary tract or bowel symptoms. So these are all better in darolutamide arm when compared to the placebo arm. So it's not just the time to pain progression, the health related quality of life with respect to the social or family well-being or functional well-being, urinary tract symptoms burden also much better in the darolutamide arm compared to the placebo plus ADT arm with a significant hazard ratios in the study arm. Next slide. So to conclude, as per the ARANOTE data, we can say that darolutamide plus ADT significantly improved radiographic progression-free survival in patients of metastatic hormone-sensitive prostate cancer. So there is a numerical decline of 46% of this RPFS in the darolutamide arm compared to the placebo arm. And darolutamide has showed a significant benefit with respect to all the secondary endpoint, that is overall survival, as well as the time to CRPC, time to pain progression, as well as a deepening of the PSA response or undetectable PSA response. All these key secondary endpoints have favored darolutamide arm compared to the placebo arm. And uh, darolutamide was associated with a deepening PSA response regardless of the baseline PSA to start with. And it has significantly reduced the pain time to pain progression. And with the FACT-P scale, we also know that the overall well-being, including social well-being, functional well-being, the burden of urinary symptoms were better in darolutamide arm compared to the placebo plus ADT arm. And we know that as per the safety profile data, the adverse events were more or less similar or lower in the darolutamide arm compared to the placebo plus ADT arm. So finally, we can say that from this ARANOTE study, darolutamide plus androgen deprivation therapy without docetaxel is a good additional standard of care in our patients of metastatic hormone-sensitive prostate cancer. Thank you.
Thank you, Dr. Chitala. That was an elaborate presentation of ARANOTE study where you have shown a very spectacular data where we can safely omit docetaxel without chemotherapy. We can give equivalent good outcomes. So after two splendid presentations by Dr. Tubasi and Dr. Chintala, so what I would do is I would walk on what we have discussed over past 1 hour. I would summarize the thing. Next, a real world case I would discuss, and I would invite my expert panelists to give their inputs. How do they treat such case? That is one thing. And few discussions or few practical points that we face whenever we in clinic, when we face the patient, how is the decision making process? With this premise, let me share my screen. So let's proceed with the discussions. So, what I would say is my verdict on Arason's trial is it's a very spectacular and beautifully conducted trial where it showed that addition of darolutamide to ADT and docetaxel, that is triplet combination, significantly extends the overall survival and also delayed the progression to castration resistance and maintenance of good quality of life without adding additional distinct toxicity to the standard chemohormonal therapy. And there is 32% reduction in the risk of death with a very good hazard ratio of 0.56. This is what is the Arison study that showed significant benefit as shown by Dr. Dubasi. When we come to the Aranaut study, a lot of patients would be there where we would not be able to optimize giving docetaxel and chemotherapy. If we omit docetaxel, can we have a good survival? So what this Aranaut study concluded that physicians no need to worry between the compromisation between quality of life, extension, and all. Darolutamide plus ADT doublet removes the historical barriers to the combination therapy and it offers a chemo-free option that meets the individual needs of a metastatic hormone-sensitive prostate cancer. So next, if we see the actual numbers, when we see the Arison study, that is a triplet combination study. So when we deep dive into the study, there is 32% lower risk of that. That is tremendous. Is it having with any increased complication? No, there is no increased complication and there is added minimal toxicity and it is consistent across key secondary goals and comparable adverse effects and 87.67 completion rate, especially the 90% landmark where the patients are able to complete. When we come to the Aranaut study, it has similar significantly delayed progression in metastatic CRPC, time to PSA progression, and also deep durable response, that is PSA level less than 0.02. That is one of the significant milestones. So I've had a review of the ASCO GU 2026. What abstracts do we have on darolutamide? I came across an interesting abstract that is DAROPET study. What it's aimed is, it is priming the prostate cancer so that it lights up whenever we do the imaging. That is, they gave 7 days of darolutamide regimen, 600 mg twice daily, and high risk localized in the preoperative timeline. They have seen what they have noticed is 18% of patients have increased PSMA PET application and they were able to detect few new lymph nodes that helped in significant removal and eradication of the tumor. In future, this can be exploited, especially in study where give 7 days of darolutamide, do a PSMA PET, and later use PSMA PET kind of therapy. This is another interesting study that was presented in the ASCO GU, that is ARA-SAFE. As we have Arason's data, we always ponder upon the elderly frail individual, what is the dose of docetaxel to be used? So do we use 75 or do we use 50 every 2 weeks? If I use 50, is there any compromise? So what they have done is Arason's study, ARA-SAFE study, have used the Arason's protocol and compared with ARA-SAFE protocol, which is 50 mg per meter square, as a emphasis to reduce the side effects and all profile. As you can see, there is significant reduction in case of grade 3, grade 4 side effects from 76% to 55%, and also neutropenia decreased from 67% to 18 to 30%. And it is a potential new standard of care where we can use the 2-weekly docetaxel 50 mg per meter square. It's shown consistent benefit across all types, including the adult, high risk, high volume disease, independent of the PSA levels and independent of the performance status. I feel these 2 studies in this ASCO GU have added more importance to the darolutamide, adding a new dimension. It was a very, very good study and scientific study to read. And ARA-SAFE, it gives much more confidence and scientific data that we can use frequently the 50 mg per meter square once every 2 weeks with darolutamide. We have very good evidence supporting the thing. So I would discuss my case. I would request my esteemed panelists to join in the discussion. So I had a 76-year-old male presented with heavy hematuria, evaluated, found to have high volume, high risk disease with a Gleason's of 7, with a PSA of almost 36,000. He was frail. He has hypertension, coronary artery disease, hyperlipidemia. So these are the baseline evaluation. Dr. Dubasi, anything else you would like to have in this patient? Any information, any test, anything before proceeding to treatment? That is the first question. Second question is, what is the highest PSA you have seen in your patients?
Sir, it's second. So highest PSA I've seen is around like 200, 300 only, sir. This is very high.
Very, very high.
And
Yeah.
regarding the first question, sir, any other testing? I would like to see 2D echo
2D.
to see. Can you hear me, sir? I cannot
Yes,
hear
yes,
you.
you're audible. Please proceed.
1 second.
You're audible. Please proceed.
So 2D echo, because he has hypertension and coronary artery disease, and he's elderly.
Yes.
And other than that, sir, nothing.
Nowadays, we are thinking or discussing a lot of precision therapy and all. Patient asks you, he's well read, very much educated. Patient asks you whether you want to do any other test.
DEXA scan is one thing.
DEXA scan. Any genetic test, patient asks, I have read somewhere that doing this genetic test will give me an additional
1 second, sir. Actually, I cannot hear you properly. 1 second.
Dr. Chintala, you can join meanwhile.
Sir, the discussion where it is leading. So two things, sir. One, the regarding with respect to PSA. So I haven't seen this sky high PSA.
What
To
is
be
the
frank,
highest PSA have you seen, Dr.
so the
Chintala?
highest PSA I have seen around 500, sir. So
500.
far, not in not this like 5-digit kind of PSA. That is first thing. Second thing, the one thing I would like to know, as patient is elderly with a lot of comorbidities, frailty, and coronary artery disease you have mentioned. So the ejection fraction, how the left ventricular ejection fraction, that one thing I would like to see, sir. And third thing, the question what you are asking, a well-bred patient, highly educated,
Hello.
keep probing, what else? So I know, with the availability of NGS and the BRCA testing, but I am very much restricted at this point of time in doing so the BRCA testing. Of course, once we exhaust the standard lines of therapy and we have reached CRPC setting, that is where I would like to do the BRCA testing. Otherwise, at this point of time, I'll still restrict in doing the.
So, Dr. Dubasi, would you agree with Dr. Chintala about doing BRCA testing or ATM testing or HRR testing upfront or later at progression? So, how do you manage that scenario, Dr. Dubasi?
Sir, I can basically because he is elderly, I would go for upfront BRCA1, BRCA2 testing because there is ongoing, evolving evidence that we can use PARP inhibitors upfront also. So I would like to get at least BRCA1, BRCA2 testing set, not like, but not in total NGS.
So, actually, the field is moving where there are emerging data of using PARP inhibitors upfront. There is a data that shows that the docetaxel, when we compared with the PAR patients with HRR and without HRR, the efficiency of docetaxel is little bit less in patients who have HRR deficiency. So that is one thing. So in this patient, I have done the NGS upfront, where it showed some mutations in the form of KDM6A, ASXL2, MLH1. So these are the mutations that have been shown in this setting. And this implies that these mutations show the prostate adenocarcinoma is very aggressive. And possibly this is the reason where we have in this patient very high level of PSA. So these are the challenges I have faced in this case. So we have a CSPC with high volume, high risk, Gleason of 7, presenting with heavy hematuria. So, any other challenges you see in this patient, Dr. Dubasi? So, how do you take a decision about how to treat? Because the volume of disease is very high. At the same time, the patient is frail with coronary artery disease, hypertension, hyperlipidemia, and frailty. So, Dr. Dubasi, if this case comes to you, how
Sir,
do you
again,
treat?
the factors to consider basically, we have to do comprehensive geriatric analysis and polypharmacy, sir, particularly polypharmacy, and whether patient is able to take all those medications independently or whether he's taking someone's help, and all psychiatric issues, whether he's having some psychiatric issues or not. So considering all those factors, if he's fit enough and taking care of himself and performance status one, then I might go for triplet therapy with low dose of docetaxel and another ARPA agent, whether it is dorolutamide or abiraterone. But if he is having polypharmacy and not able to take care of himself and is dependent on someone, definitely I would like to go for doublet therapy only. Then initially I would definitely go for doublet therapy if all these factors are considered.
Dr. Chintala, these are the possible factors I could isolate and present to you in this patient. So, with these factors, how do you decide the treatment schedule versus triplet versus doublet, or using a triplet with, as I've discussed, RSF study with 50 mg per meter square where there is low neutropenia and all. So, how do you decide in your case, Dr. Chintala? Dr.
Sorry.
Chintala?
Yeah. Can you hear me, sir?
Yes, please proceed.
Yeah. So this patient is an elderly, frail with comorbidities. So giving chemotherapy is a bit tricky in this patient.
Dr. Dubasi told that he would give 50 mg per meter square.
Maybe, sir, I would like to start with the ARPI with ADT. Of course, the patient tolerance is better maybe at the end of second week, or the fourth week. Maybe that is the time, based on the improvement in the PS and his general condition, the frailty. Maybe I would add, considering the docetaxel based on the the high risk profile of this patient, that is high PSA and the high volume disease, high risk nature of the disease, not at the upfront, maybe at the second week later.
So the next question is which ADT, which ARPI?
So the ADT I would like to consider in this patient, coronary artery disease, most likely the LHRH antagonist. Uh, that is one thing, and the other thing being he has a high volume, high risk disease. So to prevent the cord compression, all those things, I think antagonist, and as well as the cardiovascular safety also antagonist. And with respect to ARPI, so as this patient is very frail and diabetic, so out of the treatment armamentarium is abiraterone, because it would require prednisolone, which again have the managing issues of the hyperglycemia in a patient of existing diabetes. So the maybe non-abiraterone related ARPS is the way to go. And of course, we know that as per the data of darolutamide is the one we can consider, and the ADT being antagonist of LHRH.
So very beautifully explained. So especially in a high volume disease, as Dr. Dubasi and Dr. Chintala agrees, that we would tempted to give docetaxel. The main reason being is the resistant clones that are there in a high volume disease are possibly eliminated by chemotherapy. So that is the postulate, and it has proven multiple times. We tend to add chemotherapy, but in this patient, considering the frail PS, and also there is a high risk of fall, polypharmacy, and he wants very minimal side effects. Doctor, you give me a treatment which has no side effects, so I want to die peacefully. I don't want to die of side effects. This is what the patient asked me on the first day when I met him. So considering all this, as Dr. Chintala told me, I did not dare to give chemotherapy. In this patient, I have started as Aronet protocol, where I did ADT. I give only the oral relugolix kind of thing, and darolutamide. So these are the various high risk factors that I have encountered in this patient. elderly, frailty, PS2, not fit for chemotherapy, and the patient doesn't want anything. High volume, the crack score was very high, and he want very early response and control of hematuria. That is, there is high burden of disease and frailty. This is a difficult combination to have where we need an early response. At the same time, we do not give a higher agent. That is the reason I chose, because of the cardiac comorbidities and all. We have chosen GnRH antagonist in the patient, that is relogolix, and simultaneously we have given darolutamide. So we have started relugolix and darolutamide. Within 1 week to 10 days, he has good improvement in the general condition and symptoms. This is a July 25, the PSA of 36,000. In September, it has come to 10.8, and December, it has come to 0.47. Dr. Chintala, now his patient is in front of you with a PSA of 0.45. He's perfectly fine. Would you add docetaxel now?
Sir, again, this is a good case of doublet having a very good response. The sky high of 36,500 falling to less than 0.5, which is a very good response. So, as this patient is 77, having already comorbidities, and he has achieved, very good response with the doublet, I still would like to continue the doublet, uh, even after having achieved this response at the end of December, sir,
So
because
the
we
reason
need to have a good quality of life. It's not just the disease control alone in this patient. Uh, so that's why I would like to still continue the doublet. Maybe I reserve the dosy for the later lines, not at this juncture.
no, patient considering the tremendous response, now he is asking that, sir, I want cure. So I am okay for taking chemotherapy. So will you give me? So this is what patient asked. So how would you counsel the patient? So would you give, and or what do you say, Dr. Chintala?
Sir, if he's willing to take that risk and if you want the long-term cure, maybe I start with low dose. If it tolerates, I'll give. Otherwise, maybe the 50 milligram per meter square, 9 cycles. Otherwise, if there is a poor tolerance, then I will end the further subsequent cycles, just continue the doublet alone.
So if the
But
patient is
considering his age and comorbidities, I'm not sure whether he's going to tolerate this cytotoxic chemotherapy.
Dr.
But
Dubasi,
even in the trial, sir, basically we don't know exactly. It was started in less than 3 months or concurrently. So even after achieving such a good response, if we add docetaxel, we don't know whether it's going to have another, whether it will have added benefit or not. We don't know exactly. Even if we add docetaxel, it's not going to cure. It's just increasing the progression-free survival and a bit overall survival. So considering all factors, sir, I would not add docetaxel at this point of time. After 6 months of therapy, sir, with such a deeper response, and seeing these figures are really amazing. I am very happy, like seeing really 36,500 and going to 0.47. What more do you want? I think it's a good response. Nothing to add, sir.
so what I showed him at this point of time, I showed the charts of Aranode. I showed the very wide separation and all long-term survival is also seems to be looking better with Aranode. So then he agreed. So I'm continuing him on the doublet therapy. I did not add docetaxel. So this is what happened in this patient. And generally, I would ask Dr. Chintala, the first question, do we have anything like functional cure in metastatic HSCP? Hormone sensitive prostate cancer. What is that component you would achieve that would predict long term outcomes whenever you treat a patient? Is there any biomarker? As in CML, we see that achievement of deep molecular response, MR 4.5, portends good outcomes. Is there anything in prostate that gives us that this is functional cure? Dr. Chintala?
Uh, Sir,
Maybe
I'm not
PSA
sure.
level?
I'm not sure, sir, with respect to prostate, the biomarker kind of thing where we can predict the functional cure of thing. But the patients who have achieved a very good response with respect to baseline PS and the timeline at which they have achieved the deeper response PSA, they tend to have a longer the radiographic progression-free survival. But whether I can call this term as a functional cure, that is I'm a bit skeptical.
Right. Dr. Dubasi, if a patient achieves at 6 months a PSA of less than 0.02, so can I see this landmark achievement as long-term cure?
Yes, sir. Definitely, the pace at which PSA has decreased uh, shows how long he is going to respond. Like in Arasent's trial, also the patients who have PSA at 36 weeks has good progression-free survival and overall survival, rather than compared to that of patients who did not achieve undetectable PSA at 36 weeks. So it definitely PSA, the fall in PSA or undetectable PSA depicts the biology of the disease, and it indicates how long he is going to have progression-free survival or overall survival. Then I don't know whether that can be called functional cure or not. This is the term I'm hearing for the first time. I thought it is something related to like ctDNA or something.
So what I think is practically, suppose at 36 weeks landmark, if the PSA is undetectable, less than the 0.02 kind of stuff, with darolutamide, the side effects are very minimal. So he would have long survival, as we can see in the Aronute and Arasens trial. The curve is almost flat. There is no downing of the flat. So possibly I would tell that is a functional cure where they have to take this tablet. So the other question to Dr. Chintala is, how do you decide between Arasens protocol versus peace protocol? Dr. Chintala, finances are not an issue.
Yeah, sir. So
Arasens,
the patient population predominantly benefited in Peace one are de novo metastatic high volume disease patients. So if I have to choose a regimen, irrespective of the volume of disease, so where the Arasens has showed clearly that irrespective of the volume of disease, the Arasens has a significant efficacy as well as safety profile compared to the piece one data, sir. And the other thing is whenever the patient is having a dysglycemia or poorly controlled hypertension, where you required a combination of steroid along with abiraterone, so those are the patients I would ideally exclude in starting the piece one regimen compared to darolutamide plus ADT arm, where even the patients of diabetes we can include and we can manage safely. So this is two subcategories of patients where I'm tend to choose Arastins over peace.
Dr. Shravan, going to the third, Dr. Dubasi, going to the third question, doublet versus triplet. So how do you decide Arasens versus Aranode?
Sir, again, multiple factors, sir. If patient is like trial, polypharmacy is there, and psychiatric issues are there, and he is dependent on family members for his drugs, then I will definitely go for doublet therapy. If he is young, fit, and at least he can come to hospital on his own, then with high volume of disease, then I will go for triplet therapy. Otherwise, quality of life at this stage, at that age and at that stage of disease, quality of life is more important. So, considering all factors, I would go for a doublet therapy at like age, elderly, trial, and polypharmacy and psychiatric issues only, even if you high volume disease.
So how do we decide is if the patient is fit, high volume disease, possibly give a triplet. If there is frailty or low volume disease, possibly give a doublet. This is how we tend to choose in our liver world. So Dr. Chintala, in your clinical practice, how important is the combination of delayed progression and when evaluating the treatment option of metastatic HSPC? Dr. Chintala.
Yes, sir. So we know that these patients are elderly, more than the median age of 65, 70 years. So it is not just the quantum of life that is overall survival important. So maintaining a good quality of life with a reasonable progression-free survival is a very, very paramount. So we need to strike a fine balance between the quality of life whenever we're choosing a treatment, because we do have a plethora of options, and at the same time we need to have a good radiographic progression free survival. So it is a fine tuning of choosing an agent whenever we have this kind of situation, especially in this elderly age group patients.
So, Dr. Dubasi, we have already discussed the fifth question. I would ask you the sixth question. So, what are the challenges you face in your day-to-day practice when choosing doublet or triplet regimens, especially in your day-to-day practice in Hyderabad?
Sir, in the current situation, sir, I think there is no if patients are coming from like two-tier cities or two-tier cities, if patients are coming from two-tier cities, then patients will prefer doublet regimen. And finances wise, sir, if we use abiraterone and docetaxel, basically, if they are coming from two-tier cities or finances are an issue, then majority of the patients want to go for doublet. If they are from the Hyderabad itself and finances are not an issue, or if they are empaneled patients, it's easy to give triplet regimen. These are the two things where I find triplet regimen is difficult to be, even though if they have high volume disease, are fit to get triplet therapy.
Right, right. Dr. Chintala, your personal experience of use of darolutamide?
Sir, I have used in one patient. So far, he's doing fine, and
You have
I
used
didn't face much
Aracent or Aranote? Which protocol? Aracent or Aranote?
Aranote, sir, Aranote, not Arasens.
Right, right. So how long is he on the drug so far?
4 months, sir.
4 months. Yes. Dr. Dubasi, your experience with
Sir,
darolutamide, special side effects or any issues you faced while reviewing the drug, or everything is fine?
no, sir, I haven't got a chance to use it yet. So after seeing the data right now, in this webinar, I am keen to use it in my next patient, sir. Whoever is eligible, I will definitely try it.
I think we convinced you for darolutamide, I think.
Yes,
So
yes.
I think that makes my job easier. So the thing is actually the drug is very effective. At the same time, what I see is the side effect profile, the drug-drug interaction, especially in the question 7 we have, it is very pleasant because the prostate is a disease of the elderly where the patient would have multiple comorbidities. Essentially, they would be on some cholesterol lowering drugs, then some cardiac medication, some antihypertensives. So always this drug-drug interaction is an issue, and they have a tendency to fall. So as we see, this darolutamide has negligible blood-brain barrier penetration, so that the risk of falls that were there with enzalutamide and apalutamide are lesser. So I think with this, what I would conclude is whenever we decide between doublet and triplet, the patient should be able to tolerate and accept docetaxel, possibly having high volume disease where the chances of having hormone insensitive clones are higher, and hit hard and early in a younger age, high volume and disease. And when docetaxel becomes an obligation in that scenario, this and always look for any role of what do we say, PARP inhibitors. There is evolving role even in the CSPC setting. With this, I conclude. Thank you very much, Bayer, for providing this opportunity. We had a healthy discussion on when do we use doublet, when do we use triplet, the dosing of docetaxel. We have discussed the latest ASCO GU updates where there is a fantastic phase 1, phase 2 study of increasing PSMA expression, and also the safety of 50 mg per meter square of docetaxel with darolutamide as shown in ARASAFE study. With this, I conclude from my side and thank Bayer for providing this platform. And I thank my esteemed panelists, Dr. Shravan Kumar Dubasi, Dr. Shravan Chintala, for providing beautiful input so that we could conclude on few of the things and also streamlining our decision-making process. With this, I would hand over back to the organizers. Sandeep, hand over to you.
Thank you so much, sir. I'm audible, sir?
Yes, yes.
Yeah. Thank you so much, sir. On behalf of Bayer Oncology, my sincere thanks to Dr. Shravan Kumar Dubasi, Dr. Shravan Kumar Chintala, and Dr. Santosh Kumar. Excellent presentation and discussion on prostate cancer. There is a recent developments in MHSPC. So thanks to all the audience for patient listening. With this, we can conclude the session, sir. Good night to all. Thank you, sir. Now we can log out the session.
Good night, everyone. Thank you.
Thank you. Good night.
Thank you all. Thank you, Bayer, Sandeep, Santosh, sir.
Thank you, sir. Technical team, please end the session. Technical team, are you there? Technical team? Anyone from AlphaMed?